Society Town Hall meeting. We are so fortunate tonight to have Jean Acevedo back with us for a second night. Jean is a very special friend of the Palm Beach County Medical Society. Most of you know her. For those of you that do not, it's my pleasure to introduce her. Our topic for tonight is documentation for E&M, office visits in 2021, part 2, applying the new requirements to your documentation. This is going to be documented, recorded this evening. So, and it will be posted online in a couple of days before Mindy gets it online, but it will be recorded. So for your pleasure. So welcome, great to have you here. And last night, Jean brought us a lot of good news. And I understand we have more good news tonight. Is that right, Jean?
Oh, yeah. Yeah.
Okay, so a little bit for those of you that do not know Jean, which I cannot imagine, is Jean has over 30 years of healthcare experience. She has more credentials, and as you see on the screen, that is very challenging to say all of those. And she is founded Acevedo Consulting in 2000. Her expertise is in chart audits, compliance, education relative to physician documentation, and coding. She's also been an expert witness in civil litigation and an investigative consultant for the Department of Justice and in federal fraud cases. We know Jean is especially sought after speaker and possesses the unique perspective of how to avoid risk and liability while optimizing reimbursement in this highly regulated healthcare industry. So we know that what we have going on now represents some of the biggest changes in more than 20 years. And we are so pleased that Jean is here to present to us and is presenting around the country to many groups. But she calls Palm Beach County home, and we're very proud of that. So thank you. Jean, I'll turn this over to you.
Thank you so very much, Tana, and good evening to everybody. So yeah, this is part 2, and I know lots of folks who are here this evening were also sitting by their computers last evening. So thank you for coming back. Because not everybody I know would have been able to, or maybe even wanted to sit through 2 sessions on documentation and coding, I am going to briefly mention my disclaimer again. I always have a disclaimer in my talks. I rarely read anything from it, but this year it's important because there are a couple of facts about what's happening to the changes with office visit coding that are not set in stone. And that's because the final 2021 Medicare physician fee schedule rule has not yet come out. So what I'm going to talk about this evening, as opposed to last night, I think everything is, there's one area that I'll make sure I bring up that I'm not so sure how it's going to change, but we'll see. But other than that, everything, the AMA and CMS have both agreed on getting rid of your 1995 and 1997 evaluation and management documentation guidelines for office visits. I actually today, which I wasn't able to say yesterday, but today I found out that the AMA is indeed working on implementing these types of changes to other evaluation and management service codes, which will be a blessing. And I think that tonight's different approach to these changes will definitely help you to understand that. So last night I went through all of the granularity of these changes. And tonight I'm going to just do a little refresher and then get into, okay, so how does this actually apply to physician documentation? So, and the first part about just a little refresher is that as I mentioned, I'm sure that there are folks this evening that weren't able to attend last night. So I'm going to first talk about coding office visits based on time and some discussion, examples, and then coding office visits based on medical decision-making with some discussion and examples. I will stop after each section and ask Mindy, who's here from the Medical Society, thank you, Mindy, to see if there are questions so that they're fresh in your minds before I move on to the other section. And then obviously at the end, if there are additional questions, I'm happy to sit here and answer them for you if I can. So just that little refresher. Why are we here? What the heck is happening? What's really happening come January 1, 2021? So office/other outpatient evaluation and management services are the CPT codes that are impacted by these changes. I'll say it once, I'll probably say it a couple of times. Unfortunately, for those of you who also go to the hospital, provide consultations because you're a specialist, these changes are not happening to those codes. And that's what I was delighted to hear today, that the AMA is already making plans to move all of the evaluation, or at least the next batch of E&M codes, to this new system, which you will really, really like. Can't imagine not. So what's the main difference is the Cliff Notes version tonight. So you will be choosing the level of office visit based solely on the complexity of your medical decision-making, or how much time did you spend preparing for the visit, face-to-face with the patient, your history and exam, any education, etc., and post-visit with the patient, as long as all of those activities occurred on the actual date of the patient of the office visit. And no one any longer is going after January. We'll be checking your notes for how many systems you reviewed in a review of systems, how many elements in your history of present illness. You didn't have a comprehensive physical exam from a coding perspective because you only had 7 organ systems. For your office visits, those requirements are going to be gone. What a joy that is. And whether you choose the level of office visit code based on medical decision-making or your total time spent that day will be your choice. There's no rhyme or reason. You could decide that you wanted to choose all your office visits based on time. I wouldn't recommend that. I have a feeling you'll be under reimbursed if you do that. But that is your choice. And as far as your history and physical exam, the AMA is very clear, and CMS has bought into it, that only a clinically appropriate history and physical exam will be required. So should you have a physical exam? Well, of course, right? You know, the fact of the matter is that there are some patients that I'm sure many of you are seeing now virtually that you're wondering, I wonder if I should have had him come to the office. I maybe wanted to listen to that, palpate this, right? You know, so you know that clinically that's important in words, but that's going to be the good thing, is that whether or not and to the extent of your exam will be based on your clinical expertise. So all of these changes only apply to office/other outpatient codes. So that means 99202 through 99205 for new patient office visits, and 99212 through 99215 for your established patient office visits. No, the fact that I didn't have 99201 through 05 isn't a typo. 99201 is deleted, gone, history, come January. The AMA and CMS, as they looked at all of this in preparations for these changes, realized that, one, it was hard to find any doctor who billed a level 1 new patient office visit. And 2, since they were going to just complexity or time on a complexity basis, there was really no real difference in the CPT definition. So no need for 99201. Why did they start with office visits? This was a shocker to me. I mentioned it last night. Of all of the Medicare physician fee schedule charges or payments that are made each year, 20% of the allowed charges are for office visits. I mean, that means 20% of all the imaging studies, surgeries, injections, anything paid off the physician fee schedule, 20% was office E&M. So obviously they're taking a big chunk, right? And that this is effective January 1. And I realize I should probably say, for those of you who weren't here last night, since this is a change in the CPT codebook, this is not a Medicare thing, right? Medicare has agreed to adopt the AMA's changes, but this is, because it's CPT, this is something that this is going to be the only authoritative document for Blue Shield, Aetna, Cigna, United, et cetera, all the commercial managed care payers to look to for whether or not you've coded correctly. And because, again, it's only office visits, whatever you've been using, whether you know it consciously or not, the 1995 or the 1997 Evaluation and Management Documentation Guidelines to code all your evaluation and management services, you'll still use those, for your hospital visits, home visits, consultations, nursing home visits, anything other than office visits, because those are yet not changing. The nice word, as I said with what I read today, was that I can now say yet. So from a practice perspective, since you don't need to document a history with these required elements like you do today, right? Today you have heard from folks like me or a payer audit that they've downcoded you from a level 4 new patient office visit, maybe to a level 3, because when they went through it, they said, no, you said family history non-contributory. We don't count that. And you need that for a level 4 office visit, new patient. So we're downcoding you to a level 3, right? So that isn't required. Your established patient visits, doctors very often in their EMRs have a lot more in the review of systems, past family social history, than is really required for any code. It's easy to do it in the EMR. The clinical nurse just kind of, brings it into the note for you before you see the patient. And you're really not sure how much is required because you don't know what code you're going to choose until you're finished. So better safe than sorry. Well, none of that's going to be needed. So those elements are still going to count for the other visits, but not for office visits. And for many physicians, that's 80 to 100% of where you see your patients. So what are you going to do then? Those patient history forms that your staff are then entering the data into the note today, you won't need to do that. Maybe all you need to do is go back to a simpler time when I used to do chart audits in a paper world, and I would look to see that new patient information, medical history form with all of those questions, because obviously when you first see a patient, you ask a lot of questions. That's your fact-finding mission. You don't know what you don't know to help you in your diagnosis and treatment until you ask an awful lot of questions. But doctors used to just initial and date that, right? Maybe that's all that is really needed today so that you have it to refer to, but there's not going to be any reason for all of that data to be in every single note. And then what about those fillable forms that many of you have on your website that patients can download and complete and upload into the portal or bring into the office, et cetera? You won't need to have someone entering all of that into the EMR again because you only need what you feel is clinically appropriate, right? So whether or not you include all of that in your new patient or established patient progress note is going to be up to you. But I will say, and there may be a primary care physician or two here tonight, I don't know, but I know that when I did a talk like this to a good sized group of primary care physicians in Texas, during the Q&A, one of the doctors asked, I'll never forget it, he said, Jean, does this mean that I'm not going to get 7 to 10 page notes from the specialist anymore? That I'll get just that page and a half of the information that I'm looking for from him? So know that if you are a specialist, you don't have to kill Mother Nature's trees when you're sending your notes anymore, and you may actually make your referral sources a lot happier, right? So you may want to be going through your templates, right, in preparation for this, or as the year progresses, 2021, and eliminate some of those things that you aren't going to need anymore, right? You have many of those things because they were driving your code, your coding, but they're not going to do that anymore. It's medical decision-making or time. But before you just eliminate things, sit down with whoever it is in your office that knows what measures you're reporting under MIPS and make sure you don't inadvertently eliminate something that's going to have an unintended consequence. Okay, so, and as I mentioned, yep, okay, so the exam. So history, it's whatever it is that you feel is appropriate at each encounter. And I'm going to show you some doctor's notes as we go along, and you're going to see what I mean about how you don't need it from a coding perspective. And far be it from me to tell you what you do or do not need clinically. So with the physical exam, if you're seeing patients in the office and you're a specialist and you do consultations, yep, you're still going to have to apply the guidelines. Most physicians, except in certain specialties like dermatology, otolaryngology, ophthalmology, they use the 1997 guidelines because they're the day that they start doing an exam of the belly, right? Their patients are running from the hills, so they're probably not doing an 8 organ system exam from the 1995. They have their own single specialty exams, but you won't need any of that. You don't need to count any bullets for your office visits in the exam come January 1, 21, what, month and a half from now. But if you're specialist billing consultations, yeah, you're still going to have to do that. And that, of course, from a practical perspective, is going to be, okay, how do I have these templates? Well, you know, whatever your template is now for incorporating the evaluation and management guidelines for a comprehensive or moderately complex or whatever you call it, new patient / consult, keep that one just for your consultations. Right? I mean, that's probably what I would do. But then think about how many of your payers actually pay more for 9924, 12345 to see what you keep and what you don't. And is it enough to make it worthwhile for you to document a whole comprehensive history and exam from a coding perspective, right? You see, you'd be surprised. I know I was, since I don't do billing, and I started asking some billing managers, okay, what is the payment differential now for some of these commercial plans that still pay for consultations? And I can't tell you how many times I've been told that, well, they don't pay any more for consult anymore. So you may want to find out, because wouldn't it be nice to eliminate those requirements from all of your office documentation. But there's no need to rush and change your history and physical templates. After all, you're already documenting medical decision making, right? And that's how most of you are going to be choosing the level of service for your office visits based on the complexity. You're still documenting your impression and plan, right? So take your time, no need to rush. And also what I don't want to forget, and I don't know if I actually mentioned it last night, is that medical necessity will still be important for every office visit as it is for any encounter. So as you're eliminating things to streamline your day and your physical notes, remember that you're still going to need to document a chief complaint. What's the medical reason for today's visit? And I firmly believe, since I also believe that most of you will overwhelmingly choose your office visit codes based on complexity rather than time, that the complexity of your medical decision-making is presented in a very strong sense initially in your history of present illness, if you're good at telling a story about the patient, right? So keep that, right? Of course, it's easy to say that there's no need to make any changes in anything, but cloning and copy and pasting still remains a risk area. And I've actually, I think I put it in this presentation, the impression and plan from a very recent chart audit that, oh my gosh, I don't know how I would code that from a complexity perspective come January, because I can't figure out what was actually addressed today, right? The day of the visit. So there really is a good opportunity to sit down and look at your practices, how you're documenting, and eliminate some of those things that aren't going to help you. And will actually make your notes a little easier to read and probably easier to document. And then to support the complexity of your medical decision-making, as I'm alluding to, it's really, I think, a good narrative that's going to be critical for proper coding. I've got an example in here tonight of a dictated, very recent, last month, October, dictated progress note. Yes, I work with physicians who aren't on EMRs. But this little office visit you're going to see is a low-level code today, but with these new guidelines, it's going to be a higher level code tomorrow. This doctor doesn't have to add anything. And so think about that, right? Can you use speech recognition dictation in your EMR? Something so that you can actually have that narrative that well describes your patient's presenting problems. All right, so that's kind of like some general stuff there to catch folks up to date. So let's look at the requirements and a couple of examples with coding new and established office visits based on time. So for those who weren't here last night, and to remind all of you that were, what time is counted? All right, this is the list of activities from the 2021 CPT codebook. Yeah, it's out. Make sure you get one. And as I said last night, have your manager or somebody copy the office visit section of the book and give one to each one of you that bills office visits. And you need to have that thing dog-eared while you're learning the definitions and little nuances. You'll appreciate that 6 months from now that you did that. But here are all the activities that, if they're provided by you, the billing provider, on the date of the visit, that are countable for if you're choosing the code based on time. Your time spent preparing to see the patient, so you looked at prior notes, you reviewed the lab test that you had ordered last time, actually obtaining the history from the patient and performing your physical exam, any education or counseling you're doing, ordering any tests or medications, treatment for the patient, communicating with other healthcare professionals, making referrals, documenting in your EMR. You know, I often, as I think of that bullet, as that being an allowed activity, if you're choosing your office visit code based on time, maybe we found the way to get you all to document the day of your visit. Because again, it's only the time that happened, the date that you saw the patient, that can count. So if you finish your note tomorrow, you can't use it for a time-based visit. But again, remember, I said it last night, I'm saying it again, I don't think the majority of you are going to be choosing your codes based on time. The clinicians who probably will be nurse practitioners in palliative care, right? Those, I would expect that they may actually find the time-based coding very beneficial. If you independently interpret any results, so you get into the PACT system or some other outside system to look at an image, a tracing, etc., and you document your impression, not just looking at the report, right? All of those things count towards the time, if you're using time to choose your level of service. So remember that this only applies to your office visit services, and it has to be a face-to-face encounter with the physician or the non-physician practitioner that day. So anything that you do yesterday for today's visit in preparation or after today for today's visit doesn't count. And time spent by other clinical staff, so your medical assistant, other nurse, etc., none of that time counts. It's only the time spent by you, the doctor, or what CPT is calling a other qualified healthcare professional. I don't know why our system has to keep creating new terms. So that qualified healthcare professional, I've got the definition here, but think about it this way. It's someone who works with you or for you who can also on their own bill an office visit. So it's the doctor, the nurse practitioner, the physician assistant, that's who it is. Right? So, and there is a component of shared or split visits in this that I talked about last night, but I wanted to make sure for the folks who are only here tonight that you understood this as well. Let me see, yeah. That if you have a non-physician practitioner and you both spend time before the visit, during the visit, after the visit, with or about the patient, all the unique time can be counted. So all of your time that you spent looking at the chart, giving your nurse practitioner some advice and guidance can be counted towards the total time. Her time or his time seeing the patient counts and can be aggregated for the time for the visit. But the time that you and your non-physician practitioner are together discussing the patient or both in the exam room together, if you spent 10 minutes together, that's only 10 minutes. So only the time of one individual can be counted, right? If it's 3 p.m. and you walk out of that room at 3:10, and so does your nurse practitioner, it's still only 10 minutes. Just because there were two of you there doesn't mean it's 20 minutes. So make sure that that's understood. Now, the one thing about this, and this is the area where I'm like, oh, I have no idea what the Medicare program is going to do. What I just showed you, this slide here, this information, minus my underlining, is in the CPT codebook. So that's the AMA. So any of your commercial payers, they should be honoring this. But the Medicare program has always had its own definition of a shared or split visit. And it's only been for inpatient hospital or outpatient hospital, never for the office, and never have any time components been part of it. So this is one of those areas where I'm still waiting to see what CMS is going to do. Right now, their definition of a shared or split visit doesn't meet the AMA's definition, and it's not based on time, as I said. So let's see what happens after the final rule comes out. But again, I don't expect that most of you are going to be using time most of the time, so it shouldn't be that big of an impact. And here's the chart that I showed last evening with the office visit codes. The second middle column is the typical time for CPT that's allocated for each of those codes now. And that's all supposed to be what? Face-to-face time, right? It's only your visit with the patient, the time you spent with the patient, because there's only one circumstance today that allows you to choose an office visit based on time. Right now, that's if more than half of your actual time face-to-face with the patient is in activities of counseling and or coordination of care. Next year, for office visits, there's a time range. So a 99203 is 30 to 44 minutes. 99214 is 30 to 39 minutes. Why did we go from a typical time to a range? Because today the typical time is, okay, this is how much time we think for this type of patient you would have spent with the patient. But there are all these other activities and they don't know, well, for this particular visit, did you look at a chart before the patient got here? Did you have to deal with the pharmacist to get another drug that's on formulary rather than what you would prefer to prescribe? There are all these other activities, so there's now a range. And so that makes sense when you think about it, having just a typical time when there's no typical number of activities that you may or may not do in a particular patient on a particular day wouldn't make sense. So there's the code range for each of those codes. So how would you document then, right? Every specialty at some time is going to have that encounter where time is the driver, right? So if that should happen, what in the world would you be documenting? So it's reasonable to require documentation of the actual activities and the amount of time spent in each activity. Nothing really says it yet. I think what I had in those slides tonight and last night is about all that's written about time. But you know, anybody who knows me knows that I have helped more physicians. I much prefer to do proactive work, but often helping doctors and other clinicians through payer audits. So I know that they're going to be looking for the document, what they're probably going to be looking for a year, 2, 3 down the road, right? So I really don't recommend you creating a macro that is like a catch-all for anything you could have done today. Think about it. If it's a brief visit, well, you probably didn't spend 20 minutes documenting in an EMR, but you may have spent 20 minutes documenting in the record if the patient had multiple problems that you addressed today, right? So having a macro isn't necessarily going to work. So what about some examples? So maybe total of fill in the blank, right? Minutes spent preparing for the visit, obtaining the patient's history, performing an exam, providing education to the patient, family, or other, ordering prescriptions, tests, or procedures, and documenting in the EMR. I'm not waiting for an answer, but I'm going to hope that it was crickets. And some of you are saying, well, that doesn't sound right. I thought the documentation, my patient charts were legal documents. How do I have an either or? Did I speak to the patient, the family, some other? Who was the other? Did I order prescriptions, tests, or procedures? Since when could I document either ors? No, I don't think that kind of a macro is going to fly, because 3 years down the road, you're going to go, wait a minute, I don't remember. I'm looking at the record. What test did I order, right? So it should be more specific. So maybe something along the lines of total visit time, 24 minutes, reviewed prior visit and patient intake forms, 6 minutes, obtaining history, and perform exam, 5 minutes, discuss with patient and order diagnostic test, 3 minutes, complete note in the EMR, 10 minutes, right? So, and there's FAQs, I think I put them in here tonight that I saw this morning, believe it or not, from the American Academy of Family Practice that backs me up, which I'm always glad when the physician specialty societies take a similar approach. But I would have in my template, knowing that there are going to be times where it's just a rather lengthy visit, right? And maybe not for me, the doctor, but maybe for some of my non-physician practitioners who spend more time with the patients. In fact, maybe I schedule those patients who need a little more time with those folks, right? So, or with certain problems that just are time consuming. So think about, do you have the ability in your EMR to create almost like a checklist, right? So you could put in the minutes for a reviewed prior visit, right? 3 minutes, something, right? Or check them off and then at least check them off and then have a total time, but no either ors in it, right? Something like that. And let me show you what an example might be, why I'm even spending time on time, since I've already said that I don't think it's going to be your day-to-day way to choose the level of service. So look at this little note on the left. Today, we have a stable patient with hypertension and osteoarthritis seen to discuss lab and x-ray results. Has questions and concerns about the progression of his OA and blood pressure prescriptions. This was a 45-minute visit, but 30 minutes was face-to-face, 15 was pre-visit time, reviewing the test results, the last office visit, etc. Medical decision-making, 2 stable problems, 2 different types of testing, prescription drug management. Well, this is a 99213. If we were to take this using today's medical decision-making algorithm, and for time, if we wanted to use the time, it would be a 99214, because although there was 45 minutes total spent in the day today with before and after for the patient, we can only use face-to-face time. So 25 minutes was spent face-to-face, and it says 30, but 30 doesn't get you anything more. So 25 minutes is a 99214. Let's take that same scenario and look at how it would be coded come January. So same problems, same x-rays, same questions from the patient, same total 45 minutes, 30 minutes face-to-face, 15 minutes prior in the office on the date of the visit. Medical decision-making, even with the new scheme of things, is still low complexity, so it's still a level 3, but now we can count the pre-visit time plus the face-to-face time. So we have a total time of 45 minutes. It's now a level 5. So clearly for patients that are in the office for 40 minutes or more, right? It's definitely could be worthwhile using time, because there's nothing higher than a level 5 established patient office visit. Why bother to then see what all of the complexity shakes out to be, right? So I know it's going to happen in your practice. And then let me see what I did here. Yes, I did have it. All right. So then because there are changes, and I've alluded to some of it already okay, what time can I count? Today, next year. So here's a little table I put together. So today, now, can you count the pre-visit, intra-visit, post-visit time? No. Can you next year? Yes, it all counts towards code selection. Can I count the time that I spent in other services that I'm also reporting? So the time that I spent looking at the chest x-ray that I'm going to bill for? Nope, not today, not tomorrow. Can I only choose time if more than half of my time spent with the patient was in counseling and or coordination of care? Yep, that's your limit today. Come January, nope, you're not limited to that. If I have a non-physician practitioner and he and I both see the patient today, can we aggregate our time to choose a code? Not a thing today. There's nothing that's called a shared or split visit in the office setting today. Come January, yes, you can do that. And then the next 2 lines are prolonged services, but they're all the first hour. Can you report them today if you spent an awful amount of time with or outside of the patient? Yes. Can you do it come January? No. And here's why. Oh, and I apologize. I should have updated the XXX code below it to 99417, because come January, there's a new prolonged services code taught with only each 15 minutes additional. So why would you wait for an hour, as I said last night, right? So that doesn't exist today, but available come January, and obviously a lot kinder to physicians to allow you to bill for time in 15-minute increments than waiting until you've had an hour before you can bill for extra time. Now, this is not really for the doctors, because you're going to go, what is she talking about? But hopefully for the office managers who might be here on this tonight, or when you go and you ask them to listen to this. There are 2 prolonged services codes that your staff can be billing for time they spend with the patient. Remember, I had clearly said, hopefully very clearly, that if you're choosing your office visit based on time, do not use your clinical, any other office staff other than whoever could bill for an office visit to aggregate the time for the selection of your evaluation and management code. But what if, you may have been, but wait a minute, I have patients to come in and they've got these questions and need this education. And my God, my staff, my clinical staff, my office nurse probably spends a half hour with some of these people after they've left me, right, to go over all of this. So those codes exist today and they actually are payable, but you can't bill them today with an office visit from the physician. But can you come 2021? Yes. So I didn't want to not put this in here. There's maybe 10% of you that will even go, oh, that's a thing. And for that 10%, I'm happy to have shared the information. And then to go back to your EMR, where you can probably document time for counseling, coordination of care today, how will you capture any pre-visit time and post-visit time? And if you have one or more non-physician practitioners, how are you going to document each of your times, right? And make sure that only your unique time counts, right? So I don't know, that's something to consider, right? And where that falls on your priority list is probably going to be about what your workload is for administrative tasks in your own practice, as well as how frequently that you think time might actually be beneficial for you. So as I'd mentioned, the American Academy of Family Practice just this morning published some FAQs on the 2021 E&M services. So I have inserted them here. So first question, how should total time be documented? According to the Academy, the physician or qualified healthcare professional's documentation needs to justify the time spent for the visit. Use your documentation to justify the medical necessity for the level of service that is being billed. Do not document a time range, even though the CPT code descriptor identified a time range. Document the actual time spent precisely. And I was so glad to see that Q&A because I hadn't even thought about making sure to tell you guys that. Because again, there are no ranges or either ors. Was it 40 minutes? Was it 50 minutes? What was it, doc? Don't tell me you spent 40 to 54 minutes with the patient. And for those of you going, well, who would do that? Trust me, there are folks who would do that. Next question on time from the Academy. If I am leveling the visit based on total time, do I still need to document an assessment and a plan? Yes, an assessment and plan should always be documented for each visit. The assessment and plan may provide additional information that will allow your visit to be leveled if the time statement does not have enough information. Think about it, right? Why are we even talking about any of this? It's one, to lessen your burden for documentation, but also spending your time 2 evenings in a row is to make sure that you get it right, and right to the point that when the payers come 2 years from now to audit records, you're not nervous that you're going to have to pay back money, right? So good approach that the Academy took here. If the assessment and plan is not documented and the total time is ambiguous or missing, the visit may be unbillable. If you document both medical decision-making and total time, you can level the visit based on whichever is more advantageous. I really love this approach. But you still must present documentation. Documentation of an assessment and plan is also important in establishing medical necessity and maintaining continuity of care. And we can't lose track of that last phrase there, maintaining continuity of care, because guess what? The patient still matters, right? If I am leveling the visit based on total time and have also provided additional time-based services, maybe advanced care planning discussion, tobacco cessation counseling, how do I document time for those services? Another great question that I hadn't thought of yet. Their answer, make sure to document time separately for each of those services in order to bill for them separately. The time for each service must be carved out on the total time. example. And they're saying if you were billing like a 99213 with a modifier 25 and 99406, which would be 3 to 10 minutes, 3 to 10 minutes, is it, I think, of tobacco cessation counseling. To bill them both, something along the lines of a total of 25 minutes was spent on this visit, with 20 minutes spent reviewing previous notes, counseling the patient on diabetes mellitus and hypertension, ordering tests, refilling meds, and documenting the findings in the note. An additional 5 minutes was spent on tobacco cessation counseling, discussing the importance of quitting, options for medication, and a quit plan. Easy, easy. So that's the time documentation the AAFP recommends when you have 2 time-based services in the note. And obviously you'd have your whatever initial history so that you know what the heck's going on and you've documented in your assessment and plan. That's it. That's a page, maybe page and a half. All right. All right. I'm going to stop Mindy to see if there are questions on time.
I have some code questions first, but
Okay.
you might have answered them, but I just want to put them out in case you want to elaborate.
Sure.
They asked, what about code 99211? Is that gone as well?
Okay, nope, 99211 still exists, and I think it was on my chart of the codes with the typical time and then the code range, the time ranges, but it is not impacted with these changes. It is still just a nurse visit, has no time attached to it. It is not impacted by these changes, but yes, it still exists.
Are there outpatient televisit codes other than 9921 and 9920 affected as well?
No, the only codes that are impacted by this, unfortunately at this stage, are the 9920, so your new patient office visit codes, and 9921, your established patient office visits codes. Cross your fingers that in a couple of years I'll be able to say, yes, they're now gonna only require this for, you know, and some other codes, but right now that's it.
And what about time spent by residents with patients in a teaching clinic setting? How does that count compared to the attending physician's time?
Yep, I had that question actually in follow-up from last night via email. So unfortunately, no. So if you allow me to go back to, okay. So this is the, is it this one? Yeah. The, I want to make sure I read the, okay. Yeah, so qualifying time. The office / other, and this is straight from CPT. The office / other outpatient evaluation management service for which these guidelines apply require a face-to-face encounter. Oh, this doesn't help you much, with the physician or other qualified healthcare professional. So, so they're only counting the time of, well, it actually does, the doctor and the nurse practitioner, PA, et cetera, someone who could already bill an office visit. Unfortunately, not the teaching, not the student or the medical resident at this point in time. Nothing that I have seen in all of this makes me believe that you can use the time of those clinicians that you're supervising to get to total time. Sorry. Okay, anything else on time?
Last question. That was the last question I had.
Okay, thank you, Mindy. All right, so let's look at medical decision-making. And I do think that this is going to be the majority of the instances for you, for most physicians. So today, remember, you can't choose a code just on complexity. Obviously, the medical complexity should help drive your code selection because it helps to support the medical necessity of the visit, which is why many of you have either know the mantra or have heard, just because you have a comprehensive history and a comprehensive exam on all your follow-ups doesn't mean they're all 99215s, because the patient was just here with a rash. And that's a true statement. But come January for your office visits, it's medical decision-making, regardless of the history, et cetera. So how you document that and understanding that is really going to be important. So there are 3 elements of medical decision-making come for your office visits as of January 1. And of those 3 elements, at least 2 of them must meet or exceed the code that you're selecting. And it'll make sense in a moment. So what are the 3 elements? Number and complexity of problems addressed. And as I went through last night, I don't think I have it. Yeah, no. As I went through last night, understanding what the new definition of addressed is really important. And this is one of the reasons why I firmly believe that anybody that bills office visits must have those pages from the CPT code book that have all these definitions. So the office visit section in their pocket at all times. I expect it to be dog-eared by February as you learn these new semantical terms that are going to be real important. So a problem is considered addressed if you, Cliff Notes version, for those of you who didn't attend last night, feel free to watch the video. A problem is addressed if you managed or treated, so that diabetes mellitus on metformin 500, BID, hemoglobin A1C 6.2, doing well, whatever, right? Continue on current medications. Obviously you address that problem. But if number 2 is CKD3 stable followed by nephrology, nope, there's nothing you did about that. You didn't analyze anything. The patient says they're stable. You're not doing anything about it. You're not managing it. You're not treating it. So that problem list in your record is really going to be a problem list unless you really make it clear what it was you were doing about something, right? So, and again, examples are coming up to make it a little clearer. Second element, amount or complexity of the data to be reviewed and analyzed. And it's that and analyzed that is important this time around. So I can't tell you how many times through the years I've seen, you know, like labs unremarkable. And now when I see that, I go, oh, wow, okay, this doctor has to change that because labs unremarkable, okay, what does that mean? There's nothing, obviously you reviewed it, but it's not and analyzed. And you're going to see what I mean by that coming up as well, right? I just had to change that. And the third element is the risk of complications and morbidity and mortality of patient management. And that's really how sick is the patient and what are the risks based on the patient's treatment, such as, I probably have an example in here tonight of this, but of a patient who's on drugs requiring monitoring for toxicity, right, is a high risk, and a patient who's just, she said in air quotes, on a prescription drug, moderate risk. A patient who's just on an over-the-counter drug may just be at low risk. And I say low because if I have liver problems and I refuse to stop taking my Tylenol, it may be more risky for me than otherwise, right? So those 3 elements. And this slide and the next slide shows you the codes as they are defined come January. And just as a reminder, as you look at this, you'll notice 2 things. One, the only mention of history in exam requires a medically appropriate history and/or examination. It's the same for every code. So that's up to you. God bless the AMA and CMS for finally coming to their senses and allowing that. And then it's just a matter of, since we're talking complexity, whether it's straightforward medical complexity or level 3 is low complexity, level 4 moderate complexity, level 5 high complexity. And then if you look at the established patients, the only difference is the amount of time. So you also aren't going to have to worry about, wait, this is a new patient, so I need a comprehensive history, which means, okay, a good history of present illness, past history, family history, social history, 10 or more systems in my review of systems. So I have that silly statement that a 14-point review of systems was otherwise normal, and damn it, I don't know what that meant. So I hope I asked enough questions. I hope I'm telling the truth. That's gone, right? But also that a level 3 patient is a level 3, whether new or established. A level 4 is a level 4. So once you really get to be able to recognize, this is a patient of moderate complexity. I addressed 2 stable chronic illnesses today, and I did prescription drug management. That's all you need to know. That's a level 4 patient if that's what you've documented. The extent of the documentation should be driven by your clinical acumen and the patient's presenting problems, right? Other things going on, et cetera. But if you managed or treated, addressed 2 stable chronic illnesses, and oh, I don't know, maybe it's diabetes mellitus and hypothyroid, and the metformin remain the same dose, patients on Synthroid 88 micrograms remain the same, you know, renew, whatever. That's it. That's what coders for the payer will be looking for to see, did you meet that code? That's almost too easy. So in the AMA's codebook, you'll find this table of this elements of medical decision-making table. And I think since I'm going to look to see how I can share, because you have a second attachment besides, how do I do this? Bear with me, guys. You have a second attachment in addition, uh-oh, I must have closed it. In addition to this PowerPoint that I want to bring up so you can see it, because I actually think it's easier to, I guess I have to stop sharing for a second. So bear with me. I want to find this for you. It's our little tool that we created that I've shared with you that I think you're going to find is easier to use. I know I saved it to my desktop, so let's see if I can find it easy. Here it is. See if it's up. And you go back to share screen. You find this thing. Where did it go? Sorry, guys, I am still not used to the screen sharing function sometimes with, maybe it didn't come up, with, there it is, with, what you call it, with Zoom. So let's see, how do I get you to see this PowerPoint? Let's see, it's not there, it's not the whiteboard, it's not that, it's not that. Huh, I might not be able to bring it up for some reason. Sorry, okay, well, I'm gonna have to, you do have a second, I think easier to work with tool rather than just the medical decision-making table from the AMA's CPT codebook, but we'll work with this one. All right, so codes down the left-hand side, level of medical decision-making, and you'll see the 99211 is there, but everything is NA, right? So level 2, new patient and established patient. Level 3, new patient and established patient. Different, straightforward complexity or low complexity. And I don't think too many of you are going to be having too many level 2s. Most doctors don't have too many of them nowadays anyway. This is just a self-limited, one self-limited or minor problem, no data, right? No tests or anything. And minimal risk of morbidity from additional diagnostic testing or treatment. It's not really defined, so it's probably told the patient, it's just a common cold. Go home and rest, drink plenty of fluids. Probably it, right? Level 3 of the 3 elements, it's either 2 or more self-limited or minor problems, 1 stable chronic illness. I'm going to stick with that one. 1 stable chronic illness. So maybe the patient is hypertension, hypothyroid, osteoporosis, anything like that. 1 stable chronic illness. And oh, last night I made a point, because I had all the definitions up, to let you know that a stable chronic illness is one, per the CPT definitions, where the patient is at goal. And so, you know, if I'm a diabetic and the to be at goal means that my hemoglobin A1C is no higher than 6, right? And I'm doing well. No signs or symptoms from my diabetes. I'm taking my medications and everything, but my A1C is still 6.4. You know, it's not stable. So it's at a higher acuity level. It's really interesting how the AMA has redefined these things. And again, this is one of the reasons why I think you all need to invest a little time in understanding those. So, okay, so it's one stable chronic illness. So maybe it's my hypothyroid, right? Doing fine, have no symptoms, my Synthoid's working. That's actually it. That's it. That's all. That would be it. That would be a level 3, whether it's a new patient or an established patient, right? One acute uncomplicated illness or injury. So maybe I have a URI, and let's forget about the risk. Third element, let's look at the second element, because what's required there, have to have at least one of the 2 categories. Category 1 is any combination of 2 from the following: review of prior external notes, review of the results of each unique test, ordering of each unique test. So you have ordered a CBC and a chest x-ray for my URI. You're done. Regardless of the extent of your history, regardless of the extent of your physical exam, if that's what you've documented, that my diagnosis is, and my symptoms to support that it's an acute uncomplicated illness, and you've ordered a CBC and a chest x-ray, or a chest x-ray and a spirometry, whatever it might be, you're done. That's a level 3. Again, new patient or established patient. A level 4, if you look, this is where you're going to see what I was talking about before, that 2 or more stable chronic illnesses with prescription drug management, you're done, right? Make sure your note looks like what you would like it to look like, right? That you're proud of, and another doctor, other clinician would understand and appreciate that what a fine physician you are, right? Didn't have a lot of unanswered questions or trying to figure out, well, what did you do about this problem, right? So, but if you look, because it's only 2 of these 3 elements, so what am I talking about? In the number and complexity of the problems addressed, the second bullet, 2 or more stable chronic illnesses. Let's say there's no data. You didn't order any tests, you didn't review any tests, you didn't get any history from someone other than the patient, you didn't have to talk to anybody else. Go over to the third element for complexity, and the first bullet, prescription drug management. Ta-da, done. Now, is this the area? Let me see where it is. One of these areas has something in it that, here it is. For a level 4, and I know I mentioned it last night as well, but there is something that many of you have been cognizant of, consciously cognizant of the last few years, the social determinants of health. And boy, during this public health emergency, haven't we heard a lot about that as we hear about the discrepancy between the care and the severity of the COVID virus, depending on where I live or what nationality or race I am, right? So if you look in the risk of complications and morbidity or mortality of patient management column, and you go down to the last bullet, diagnosis or treatment significantly limited by social determinants of health. So that means that if you've documented that, and maybe one of my problems is exacerbated by my diet, right? But I live in a food desert, right? Or I don't have the finances to be able to get fresh fruits and vegetables. It's just not available in my neighborhood, you know. Any of those social determinants of health, that's all of a sudden now moderate complexity. So it's social determinants of health from being something that wasn't even talked about in healthcare circles, at least not generally until, what, 4 or 5 years ago, maybe at the most, is now actually made it into the coding world with recognition that, yeah, it increases the overall risk for mortality, complications for patients when they have these other external forces that are impacting their condition. So any combination of 2 from these 3 elements is a level 4. Level 5, now we're talking about a sick puppy or a patient with an awful lot of data, right? An awful lot of tests. You got into the PACT system and looked at another record. You had to speak to another doctor. an awful lot of information, or because it's two of these three, the patient's on a medication that requires intensive monitoring for toxicity. And again, that is defined now in CBT, as you saw last night. One of the determinants as to whether or not this drug actually meets the requirements to be categorized here is whether or not the side effects are monitored at least quarterly. So at least every 3 months, you're getting blood work to look for signs of adverse effects, et cetera, right? Any decision regarding hospitalization. So the patient's sick enough where you're thinking about sending the patient to the hospital. Heck, myself once earlier this year, my primary physician sent me to the emergency department and told me, no, you're not going anywhere but to the ED, you're being admitted, right? That would have been, regardless of anything else he did, the reason he sent me and the fact that he was sending me, that made it a level 5. No more, did I have a comprehensive history? Did I have a comprehensive exam? Just your thought process and the complexity. So let's think about how might this actually impact some of your, the documentation, right? Let's look at this. So here's a note. Here's where I brought in a few notes. Bear with me for a second. I'm still notified when folks are in the waiting room, and I'm trying to get rid of that so I can not have it block my screen. Not quite sure how to get rid of that silly thing. Oh well, can't really see the whole slide. Hopefully you can. So here's a 99204 or a 99214, because remember, same medical decision-making components, right? There's no difference. So the assessment, I'm only giving you the assessment and plan from this note. History of osteoporosis, colon cancer in remission, vitamin D deficiency. Orders, medications ordered today include zoledronic acid, 5 milligrams IV once a year to be administered. We'll check labs today for further evaluation, including C-telepeptide for bone turnover marker, daily dietary or oral supplementation of calcium and vitamin D. Next DEXA due September. We'll repeat comprehensive metabolic panel 1 month after infusion. Okay, what have we got here? Right, now, I'm assuming there's some history in this note, and I'm sure when I read it, there was probably an awful lot of other stuff in that note that isn't required now, not from a coding perspective at least. So what have we got? So this is a level 4. I don't think it would be a level 4 today, but especially if it was a new patient, definitely wouldn't be. So, but come January, we've got 2 stable chronic illnesses that were actually addressed, the osteoporosis and the vitamin D deficiency. The data, we have labs. You're actually not ordering the bone density study, just to mention that it's due. So I don't even know that you're ordering, right? So can't count that. So we have labs, and there's prescription drug management. The patient's going to get reclassed. That's it. That's a level 4 visit, whether a new patient or an established patient visit, right? Easy peasy, as they say. Oh, went around spinning. Now, here's an actual SOAP note that today was coded in 99212. Pain in the subjective, pain in muscles and joints resolved on prednisone 20 milligrams a day, remains improved at 10 milligrams QD with some discomfort in shoulders and legs. No joint swelling or other musculoskeletal symptoms, has not yet had lab done. There was no exam, and it was telehealth, so that's okay. Assessment, myalgias and arthralgias, polymyalgia rheumatica likely, plan, CBC with diff, SED rate, metabolic panel, free T4, TSH, CPK, and ANA. 2, continue prednisone 10 milligrams a day and return in 1 week. Well, today, yeah, this is a 99212 based on complexity. We have 1 stable problem, right? So that's straightforward complexity, 99212. Data, the only data that's reviewed, ordered is lab. And today, remember, there's a point system, so there's 1 point. Today, it doesn't matter how many labs, right? Today, you get 1 point per lab, regardless of how many. Come January, you get credit for each unique test. So again, straightforward. And then the overall risk, well, the overall risk is moderate because the patient's prescription drug management, the prednisone, right? But 2 of the 3 variables today are at straightforward, which is a 99212. Okay, so today this note is a 99212. Same note, coding it in January. So don't have to reread it to you again. Now it's a level 4. All right, how did I get there? We have 1 problem that was addressed. So 1 in that element today would get us to a level 3. Data. We have 3 or more unique tests that were ordered. So that gets us, because the doctor has delineated each test. So that brings us to moderate complexity, 99214, and we still have the prescription drug management, 99214, and I see a typo. No, there is no code 099214. So that same little SOAP note, and this is the entire note, is a level 4 come January. Nothing else in there that's needed. There's probably, some of you might think, well, why didn't he ask this, or why didn't he do that? Remember, the exam was because it was actually telehealth, but I used it because of the fact that, well, it's only a clinically appropriate exam next year anyway for office visit. So I can choose this little visit, because when I read it, I went, oh, this is correctly a 2 today, but it's a level 4 come January. Oh, and although this was coded today a 99212 by this physician, in January, if he had the same note, it would be a level 4 established patient. If this was his new patient note, it would still be a level 4 come January. Because remember, there's no difference. Now, you clinically, obviously, are going to have a lot more history, right? The first time you see a patient, because you want to figure out what's going on. This patient is known to this physician, didn't need to delve further into anything. Well, what about past history? Do you have any family history of, some other type of musculoskeletal immunologic disease, so, but that's technically all that is needed, right? Because it's complexity. So if you think about that, what was really important here was that narrative, right? That just tells me about the patient, tells you about the patient. So depending on how your EMRs are set up, you've got a point and click history of present illness. Oh, I don't know how well that's going to fare in these this new era. I know when I read those notes, I really have trouble trying to figure out, okay, wait, how stable is the patient or not? Is this a new problem? Is this an established problem? Things aren't that clear. So if you are able to document your thought process, 20 years ago, I used to tell physicians, and one of my associates has always been telling me that, Jane, you need to go back to telling doctors to think in ink. So I'm reactivating that expression. If you're able to think in ink, you don't have to have a lot for a level 4 visit, right? There you go. And a list of labs with results isn't also going to be enough. So if you had CCP 156, rheumatoid factor less than 10, negative ANA, okay, so is that really countable? Or most recent CBC, CMP without evidence of adverse effects of, if it's like the, sorry, I didn't mean for the data, where in the risk element for the drug therapy requiring intensive monitoring for toxicity, I very often will see just if a patient's on a drug that requires labs to monitor for toxicity, just the labs listed with no correlation to the drug, never mind what you're looking for something with the drug, right? So most recent CBC, CMP without evidence of adverse effects of fill in the blank for the drug can raise the level of complexity from a moderate to a high, right? Based on these new guidelines. And then whether it's rheumatologic, because that was the type of condition in the last note, or any other specialty, how are you going to define goal, right? Remember, I just reminded you that a stable chronic illness is one that's at goal per the definition in the CBT code book. So endocrinologists do that really well, right? Diabetes is at goal or not. Hypertension is at goal, right? Blood pressure is at goal. Lipids are at goal. I mean, because they have something, they have a numeric value that they can use as goal, right? And of course, the patient who isn't at goal isn't as stable, right, as a stable chronic illness, right? They have a higher acuity level, i.e. could be a higher code. So how are we going to do that? I'm looking forward to some discussions with physicians in different specialties to figure out how's that going to translate for you, right? And then if you have an electronic medical record that is coding things now, don't use the encoder. Right now today, I see too many notes that are coded, maybe a level 4 established patient visit, especially established patient, because the doctor documented a comprehensive history, level 5, a detailed exam, level 4, medical decision-making of low complexity, level 3. Well, technically, 2 of the 3 key components were at least at a level 4, the history and exam. So technically it's a level 4, but for goodness sake, what was the medical necessity for that more entirely comprehensive history? Probably none. You just saw the patient 2 weeks ago. Why did you need past family and social history all over again, right? So, and the EMR doesn't know if your patient's problem is stable, acute, et cetera. It's going to be interesting. And even if it has a really good component dealing with complexity, will it recognize the different lab tests, the different tests if you enumerate them? Because that's a whole new value proposition. Because today, again, you get 1 point regardless of how many labs you ordered. You get 1 point regardless of how many imaging radiology studies you order. But come January, that type of complexity is going to be based on each unique CPT code, right? So totally different. And so how will your EMR identify, right? Will it be based on order? If you order by CPT code, does your EMR do that now? Because wouldn't it be nice with all of this, since there is a formula and there are definitions, if your EMR could be legitimately more helpful? And I say legitimately because I see too many now where the encoder function is turned on. And I worry that if the doctor gets an audit by the payer, that all those level 4s, because of the history and exam, but really much lower complexity of medical decision-making might get downcoded. So maybe there's an opportunity for them to do that, right? So, and how would the EMR know if you meet the at least every 3 months for some type of testing for a drug to be considered as being monitored for toxicity, right? What's going to be in there to tell it that, right? So it's going to be interesting, right? So it'll be interesting to see how that works out. And then just remember that 2 of the 3 elements of medical decision-making must be met or exceeded for you to choose the level of evaluation management service. And because as you delve deeper, I talked about this last night, if you do a lot of tests in-house so that you're also reporting, is the words in the CPT code book, billing for would be my words. You're also billing for those tests, right? You're doing x-rays, you're doing ultrasounds, et cetera. You're doing EKGs. Well, you're not allowed to, the test that you're also separately reporting like that has a physician interpretation component cannot also be added for complexity in medical decision-making. The AMA, this is the one thing that they've done that I'm going, what? It really does impact complexity, but okay. So if you perform a chest x-ray in-house, you interpret it, you're going to bill for this 70,000 code, you don't get to add that in complexity for each unique test because you're going to get paid for that test. But, if you look at the 3 elements of medical decision-making, the number, complexity of the problems addressed and the risk area could easily be driving your code selection anyway and not necessarily too much data. So you're going to really have to look at that if you're doing a lot in-house. So here's one of the things that scares me because of the copy and pasting. So this is the assessment and plan from a note that I looked at last week. This was, now I've got it in 2 columns, but these were all one after the other. And the numbering, 1, 2, 1, 2, 1, 2, 3, 4, 1, 2, 3, 4, 5 is the actual numbering in the note. Anybody want to tell me what the patient was seen for actually today and whether the patient really was having a relapse or was now stable? I wouldn't want to make bet on any of that. So this thing I flew into my, talk about copy and pasting, into my presentation because, oh my goodness, if any of your notes have any of this stuff in it, get rid of it, because I wouldn't know how to code this. Your EMR won't be able to code it. And the plan, let me tell you something, regardless, whether it's Medicare or any other insurer, there is absolutely no way that they're going to spend time trying to figure out, well, which one of these actually accurately describes what you evaluated today and what your treatment was today. How this happens, I have no idea. And I'm telling you, the way this is, I don't know if 1 and 2, the first 1 and 2 was correct, or if 1 through 5 was correct. I don't have a clue. So really, really see if this isn't the impetus to get rid of some of your copy and pasting. I've never been a proponent for it being in the assessment plan anyway, for reasons just like this, but it's going to be a big detriment to you. You won't yourself be able to look at it and assign a code. So is the patient relapsing? Is this one stable chronic illness or not? If the CBC is being ordered to, because over here on this side, we've got the update lab tests, including a CBC with diff, is it being ordered to monitor toxicity of the methotrexate that's also in this list somewhere? If so, then that's extensive. We might have a level 5 visit here, but I can't figure this out. There's no correlation. So this is probably one of the areas that would be well worth physicians spending a little time and trying to figure out, how do we simplify my notes? Because think about that SOAP note I just showed you, right? Very simple note. But come January, it's a level 4 visit where this, I'm not quite sure what we did about this note today. All right, so I'm going to wrap this up with some good questions from the American Academy of Family Practice that weren't regarding time that I was able to get today. And some of it is reinforcing some of the things I said, which is of course a good thing. Do these changes apply to any other outpatient services? Nope. These changes only apply to outpatient evaluation management office visits. All other outpatient services, including consultations and emergency visits, will continue to use the same 3 key components for leveling visits, right? So that's it. These is for office/other outpatient visits, nothing else. Since history and physical exam are no longer required to level, why is this? All of a sudden there's additional, yeah, let me get rid of something there. Oops. Since is no longer required to level the visit, should I still document these elements? Yes, and I've said that as well. Although history and exam are no longer required to level the visit, they are still important components in establishing medical necessity, supporting medical decision-making, and providing high-quality care. Documenting these components helps maintain continuity of care and assists other care team members, right? So good question, good answer. What does external mean, right? Because it's that data for tests. You can only count external sources, et cetera. Again, you need to have those definitions. External means records, communications, and or test results from an external physician or qualified healthcare professional, or external facility or healthcare organization. An external physician or QHP is an individual who is not in the same group practice as you, or is in a different specialty or subspecialty. This is similar to the rules for defining who qualifies as a new patient. This was a good Q&A, especially if I have any primary care physicians on this evening. If a patient presents for a Medicare annual wellness visit and follow-up for chronic conditions, what are the documentation requirements for the evaluation management service? So if you've met the requirements for outpatient office E&M, an office visit can be billed based on medical decision-making in addition to the Medicare annual wellness visit. However, if you use total time to level the E&M visit, along with an annual wellness visit, you'll need to carve out the total time for the office visit, specifically in the note. And remember, the example earlier with time was the same type of scenario, but with a visit and smoking cessation, 2 time-based codes, right? So again, the example of a 99213 modifier 25, and G0439, a subsequent annual wellness visit. Their suggestion, a total of 45 minutes was spent on this visit, with 25 minutes spent on performing a physical exam, counseling the patient on managing diabetes and hypertension, refilling medications, and ordering labs for monitoring chronic disease. That should be enough to show the payer that, yep, this was totally separate from the annual wellness visit, pay me for the evaluation and management service in addition. Is use of over-the-counter medications automatically considered low risk, as it was under the previous guidelines or what you have today? Over-the-counter drugs are not necessarily without risk and therefore are not necessarily considered low risk for purposes of medical decision-making. For example, recommending an OTC medication to a patient with several comorbidities may still result in a detailed discussion of risk. Therefore, each instance should be evaluated individually and not automatically characterized as low risk. And I think I mentioned something about patient on, keeps taking their Tylenol and has liver problems, right? If I order, this is an important question and answer. If you are ordering, reviewing any lab tests or any tests at all, any diagnostic tests, if I order a test during one visit and review the same test during the next visit, can I count this as a data point for both visits? So do I get the complexity point for ordering it today? And when I see the patient in 3 weeks, I get it again for review and analyzing it? No. You can only get 1 point for this lab. So the order and review of results is part of the data ordered/reviewed during the first visit. Yeah, because that's the other question is then, okay, if I only count it once, which time do I count it? It is not considered a unique data point in a subsequent encounter. When you order a test, it is assumed you will review it. Therefore, both the ordering and the reviewing is attached to the first visit. I love the way they said it because it actually makes some sense. But here's a little twist on that. If I review a previous A1C and order a new A1C during the same encounter, does this count as 2 points under data reviewed? No. Each unique test will count as 1 point, and a unique test is defined by its CPT code. Since this is the same test with the same CPT code, the reviewing of the previous test and ordering of the new one will together count only as 1 point. I hated that answer, but I get it, right? That was it. And perfect timing because I see that someone has a hand raised. So I am ready to take questions.
So I have a question from Brandy. It says, can you bill for a nurse's visit using MDM or timed method? If both, can you briefly explain and what codes would be the best?
So a nurse visit, I look at as that patient who's seen by your office nurse, the medical assistant, RN, LPN, nurse visit. That's still just a 99211. Nothing has changed with that. They are not only someone who can be credentialed and is credentialed in the Medicare program and can bill any office visit code, can bill higher than a 99211. So nothing's changed there, still a 99211.
Okay. And then I have Dr. Dresner has a very long question. As primary internists referring to a consultant within managed care plans, we are frequently asked to authorize a certain EM code level, for example, 99214 for a routine follow-up for a patient prior to the actual visit. Can you comment or express your opinion on whether workflows for such coding authorizations might change as well, given the 2021 EM coding changes?
Oh, great question. Oh, wow. Yeah, I've always thought it was a bit weird that the managed care plans required the referring ordering physician to tell you, the patient doctor who's going to see the patient, what level of service you were going to be allowed to bill for. Nothing's really changed there. And even today, because I know I've had physicians approach me with this when they've been, say they got a referral for, it was a 99204. And when they saw the patient, they were like, Jean, it's not a level 4, it's a level 3. What do I do? And I've never had a really good answer. My first answer is always going to be, well, then charge the level 3. Because I have a feeling you may not get denied. And I just thought about it. I don't know that anybody's ever gotten back to me to let me know if they did that. And if they did they get denied? So nothing's really changed there, Doc. So, wow. And yeah, this is real. So you know what? So I guess what you're going to have to do, or the doctor who's going to be completing the authorization, is based on your understanding of complexity, right? What level do you think it is? Are you sending the patient for 2 because the patient has hypertension and AFib, right? And it's not that they are not controlled, right? So that maybe they're 2 stable chronic illnesses, but you know that with everything else you deal with, you just need cardiology to look at this patient. Well, I would order a 99204 because 2 stable chronic conditions with prescription drug management, and obviously the patient's on something with those 2 conditions, right, would be a level 4. So you're going to have to use your best judgment like you do today. Wow, interesting. Huh. Thanks for that question. You made me think.
Well, he's still making you think, because the next question is, what are the anticipated changes in the Medicare reimbursement of the 2020 codes to the corresponding codes in 2021?
They're going up. They're all going up. You're going to have to document less. And as you saw, codes that might be a level 2 or 3 today may easily be a level 4 come January. And the amount that you're going to get paid is going up. And for depending on the specialty, it's double digits that's going up. I think endocrinology is going up 16 or 17%. Rheumatology is around the same, 16, 17%. And for certain specialties, so you really need to get last night's session, there'll also be an add-on code that is one of the things that I'm still waiting for the final rule to see for 2021, how the Medicare program is handling it, that you would bill in addition to your office visit, regardless of what level, regardless of whether you chose the code based on time or medical decision-making, just because you're you, I like to say, that if you're managing any complex ongoing problems, that will pay you an extra $15 approximately, right? So yeah, based on your office visit codes, these are, I think every single one of them are going to pay more in 2021 than they are today. And again, for less documentation. So I was happy to get that question.
What are the anticipated changes in the work RVUs of the 2020 codes to the corresponding codes in 2021?
So the work RVU component has gone up, right, of the total RVUs, which is what's why the result is higher reimbursement. If that doctor wants to send an email, I'm happy to send you something from the proposed rule. And remember, it's just proposed. We're all still waiting for the final 2021 rule to come out. And because CMS has been busier than ever because of the pandemic, just like many individuals, right? And they really have been. They've had to deal with a lot of changes, and they've actually handled it extremely well. They've actually told the general public that they may be a little late in getting the final rule out, but I know that they must have it out by December 1st, because if I'm not mistaken, by law, the public, so you and me, we have to have at least 30 days notice before things are implemented, which would mean December 1st would be the latest. So the final rules with the final RVUs will be out, but I can send the doctor a file if he wants to email me for the information as to what's proposed at least.
The last question is from Dr. Boyer, who has his hand up, so I just unmuted him.
Yep. Hey, Doc.
And he's unmuted.
Whoops, so is my puppy all of a sudden. She was so good all this time.
Can you bill that add-on code GPC1X every time the patient comes in for a visit, or is it just one time?
So that's the code, and that code is what you just said, the GPC1X, that's what's called a placeholder. It's not the actual HCPCS code. So, but CMS is just put that out as, hold the place for the real code when it comes out, effective January 1. And it has, I'd have to bring up last night's presentation. Its intention is to be used for every office visit where you are managing an ongoing chronic problem or one complex acute problem. So I look at it this way. From what we know today, only the final rule will be the arbiter of whether or not what I'm saying is what will be. That if you're treating a patient you're the person responsible for their diabetes or their heart disease or their chronic kidney disease, their thyroid disease, their osteoporosis, their rheumatoid arthritis, their psoriasis, you're the doctor responsible for that. It is expected that that G code will be billed to Medicare because it's a HCPCS code. So I don't know yet. No one will know until probably the first quarter of 2021. But it is as defined, it looks as if that code will be billed with each and every office visit, not just one time. I mean, this is one of the reasons why for most internal medicine specialties, the reimbursement from a Medicare office visit perspective is going up so high. The physicians who won't on the other, the Medicare program has this budget neutrality component in its formula for the fee schedule. And which means that, okay, if we're going to add reimbursement, increase the RVUs for office visits substantially, and it really is fairly substantial, then we have to take that money from somewhere else. So the proceduralists, the cardiovascular surgeons, the orthopedists, right? Unfortunately, they're going to have some of their RVUs go down. The AMA and obviously some specialty societies have arduously lobbied, commented to CMS on the proposed rule with everything else that's been going on in 2020, especially for the proceduralists, right? So it's not like the old days, right? Where, well, they make plenty of money on their surgeries, right? Heck, they weren't able to do surgeries for months this year. They have many societies, including the AMA, have stringently commented to CMS, is there any way that you can not apply the budget neutrality factor this year, right? And that's something that we'll all have to wait and see what happens in the final rule. I don't know if CMS has the ability to do that, but I can understand the request, that's for sure. So I hope
Dr. Boyer, did you make it in? Well, he's unmuted, so I guess we're finished if we can't hear him.
Okay. All right. Well, I thank you all very much. I hope this helped clarify, especially some of what was last night. And for those of you who weren't able to attend last evening, for some more questions, a deeper dive into the requirements and some of these definitions I keep alluding to, that's what the first session was about last night. And I'm sure the Medical Society will let you know when and where that's available for reviewing. And I know I'd already had someone said, I wish I could go back. Wanted to pause you last night and go back and re-record and listen to that thought again. So thank you all very much. And I hope everybody has a wonderful Thanksgiving.
And Jean, thank you so very much. It was, again, an amazing presentation. You are a true treasure, and we greatly appreciate the work you do for us. So thank you so very much. And thank you all for joining with us tonight for this presentation. Just like to remind you that on December 5th, we will be celebrating our Heroes in Medicine and our installation of our incoming president, Dr. Roger Duncan. So check your our website, or you should be receiving something in the mail. Hope you can join us for our virtual presentation. And thank you, Mindy, for your help tonight. Everyone have a great time.
Thank you, everyone. Thank you, Jean.
Thank you.